The Limi Children Hospital is a multi-specialty children hospital with advanced specialty in neonatology, pediatric cardiology, neurology, hematology, nephrology, and vaccination. We provide a variety of clinicians to help deliver the best possible care. Our physicians and nurses have been recognized by a number of independent organizations for overall excellence. We offer consulting services, regular nursery care, premature birth care, and treatment of babies with mild to severe illnesses across our different integrated facilities. Our neonatal intensive care units are well equipped with infant warmers, incubators, phototherapy, monitors, ventilators, and oxygen hood or nasal cannula. As a baby's and family's first pediatric caregiver, our neonatologists often begin their work by providing prenatal consultation to women experiencing preterm labor, carrying multiple babies, or following the finding of a possible congenital malformation that may require special preparation for the birth and coordination of treatment services for the infant. For more information, log on to www.limichildren.org.
So we are going to talk about management of stroke in children with sickle cell disease. I introduced myself earlier as Dr. Akudo Kanu, and here with me is
Dr. Ogbonna.
Good. So just listen and get informed. So the objective of our topic today is to identify what stroke is, how to manage causes, risk factors of stroke in sickle cell disease, to know and implement appropriate treatment intervention, to know how to reduce risk factors, prevent stroke in sickle cell disease. So here is a case scenario. A 16-year-old female non-HBSS presented with headaches, hemiparesis, speech disorder, facial weakness, drooling of saliva. And on examination, he had a heart rate of 88 beats per minute, respiratory rate of 20 cycles per minute, and oxygen saturation in room A of 92 to 95%. On examination, had abnormal girth and cranial nerve pulses, cranial nerve 5, 7, 9, and 12. So foot block count shows white cell count of 13,000, and heart cell volume of 21%, platelets of 219, and here is the differential. The hemoglobin electrophoresis shows the HbA of 19%, HbA2 of 3.8%, and the HbS of 70.6%, fetal hemoglobin of 1.3%. MRI done shows region of hypointensity in the distribution of the right middle cerebral artery and the anterior and posterior region of hyperintensities, which represents new fat. So I'm going to show us the MRI picture. So here is the hypointensity and then the hyperintensities that represents new infarct. So what is the diagnosis? What is the differential diagnosis? What key investigations will you do to make a diagnosis? And what will be your specific and supportive therapy? How do you follow up this patient? So here is our outline. So Dr. Victor, maybe you just take the outline.
As a way of outline, we've done some description, we've introduced the topic. We'll look at the etiology, we'll look at the diagnosis, how to make a diagnosis using both the history and physical examinations. We'll look at some special investigations that are necessary to make a diagnosis of stroke in an SCD patient. We'll look at how to make a clinical diagnosis, and we look at how to treat and follow up this patient.
Okay, thank you. So by way of introduction, stroke is a well-known debilitating complication of sickle cell disease and is one of the leading cause of death in children and adults as well. So definition of stroke is an acute neurologic injury of the brain, retina, or spinal cord that occurs as a result of ischemic or hemorrhagia. So sickle cell disease is a common cause of stroke in children, aside other causes like congenital heart diseases. So with a rate of approximately 200 times higher than that seen in children without sickle cell disease. The rate is highest in hemoglobin SS, that's sickle cell anemia, and hemoglobin S beta thalassemia genotype. Stroke is distinct from hypoxic ischemia and traumatic brain injury or spinal cord injury. So the subtypes of stroke is the ischemic stroke, where you have a brain infarction accompanied by sudden onset or overt stroke symptoms. These overt stroke symptoms, we'll talk about it later. You have the hemiparesis, aphasias, facial, palsy, facial nerves palsies and all. So central nervous system ischemia, by definition, is a brain, spinal cord, and retinal cell death attributed to ischemia. We also have another subtype, the hemorrhagic stroke, which represents 1/3 of the acute neurologic events in patients with sickle cell disease. We have the intracerebral hemorrhage, the intraventricular hemorrhage, the subarachnoid hemorrhage. So the intracerebral hemorrhage is bleed directly into the brain parenchyma, and as a result, there is formation of hematoma. Then the intraventricular hemorrhage results from bleed into the ventricles. So we are excluding that of the intraventricular hemorrhage of preterm infants where, they are frail and fragile vessels rupture. Then we have the subarachnoid hemorrhage where there is a bleed directly into the subarachnoid space. When there is now accumulation of this, blood in that space, it could lead to raised intracranial pressure. And it's also worthy to note that ischemic stroke can transform to hemorrhagic stroke. So also good to note that cerebrovascular accident has fallen out of favor. So although some, publishers still use it. I will also talk about the other types of infarct where we have the silent cerebral infarct. It is also known as silent brain infarction or silent stroke, which you will not pick on, physical examinations. So by way of definition, silent cerebral infarction is a lesion visible in a magnetic resonance imaging, and the dimension would be at least 3 millimeters with no associated findings on neurologic examination. So because on neurologic examination, there is no, clinical finding, does not necessarily mean that there is no stroke. So that's where the silent cerebral infarction comes in. And because the term is silent cerebral infarction, one could think that there's no clinical, feature, then maybe the, patient is free. So silent cerebral infarction are not truly silent because the presence of this lesion correlates with neurocognitive and behavioral deficits. So children with this come down with, poor academic performances in school. Okay, the other one is the transient ischemic attack. Historically, we used to know it as signs and symptoms of stroke that are seen in the, in less than 24 hours, then, there's reversal and the patient is normal. But transient ischemic attack refers to a transient episode of neurologic dysfunction caused by a focal brain, spinal cord, and retinal ischemia without acute infarction. So when MRI is done, there is no acute infarction seen on neuroimaging. So Dr. Victor is going to take us on the risk factors
Yeah, so we'll be looking at some of the risk factors, and let's start with ischemic stroke. The following are associated with increased risk of ischemic stroke. Now, the SCD type plays a major role in predisposing a sickle cell patient to having a stroke. Now, types of SCD with the greatest disease severity in general, such as HBSS and HBS beta thalassemia, are associated with the greatest stroke risk. The risk of stroke was highest in those with HBSS more than those with other types of sickle cell disease and HBS thalassemia. Now, other ischemic stroke risk factors are frequent episodes of acute chest syndrome. Now, when we go further, we'll see how a concomitant clinical event such as acute chest syndrome predisposes this patient to having a stroke. Also, a lower steady state hemoglobin level, such as places a risk of about 1.9 per 1 gram per DL decrease, places a higher risk of this patient having stroke. Also, higher systolic blood pressure, such as a systolic blood pressure of 1.31 per every 100 millimeter mercury of a systolic blood pressure rise, places an added risk factor to this patient to having stroke. Now, looking at hemorrhagic stroke, some of the risk factors for hemorrhagic stroke are less well studied, in as much as it occurs more within the age of 20 years to like 29 years. But the major risk factor for hemorrhagic strokes were the presence of lower steady state hemoglobin level and acute severe anemia with higher steady state white blood cell count. So we see that in these patients that are predisposed to having hemorrhagic stroke, they tend to have a lower steady state PCV and a higher white blood cell count. Now, what this does, it helps in forming a complex that brings about a dysfunction and a lesion on the intima of the cerebral vasculature, which predisposes this patient to having a hemorrhagic stroke. Also, the risk of hemorrhagic strokes are correlated also with older ages, with an incidence of 14 per 100,000 person years for the age of less than 10 years, but we see about 103 from the age of 10 to 20, with the highest number seen from the age of 20 to 30, which is about 139. Then we see as much as 518 for ages greater than 30 years. What this is trying to explain is that the risk of hemorrhagic stroke increases in SCD patients as they get older, with at least about 518 for the age of greater than 30 years. Also, other comorbidities such as hypertension, kidney disease, coagulopathy, and atrial fibrillation further places this patient at an increased risk of having hemorrhagic stroke. Now, some other genetic risk factors include numerous genetic polymorphisms, which have been associated with modification of stroke risk. In one of the series, a concomitant alpha thalassemia was associated with a lower risk factors. So when we look at the genetics, some play some form of places some of protection, while some increases the risks. One of those that help decrease the risk of stroke in SCD patients is the concomitant presence of an alpha thalassemia disorder in this patient help to decrease, whereas some other genetic factors such as the Moya-Moya syndrome increases the risk of stroke in this patient. Now, we can also look at other risk factors in children, especially children with sickle cell disease who have experienced a stroke are at higher risk of having a recurrent ischemic stroke. And this risk is about 67% within the ages of 2 to 3 of the first year of stroke. So once a sickle cell patient experiences the first stroke, is at an increased risk of 67% to have a repeat stroke within the first 2 to 3 years of that initial stroke.
Thank you so much. So this repeat reoccurrence risk is when nothing happens, or when there's no, secondary prevention therapy is being instituted. So the incidence of first stroke varies with the type of sickle cell disease, like the type of genotype, and the patient age and other comorbidities. So approximately 11% of sickle cell disease patients have clinically apparent stroke before the age of 20. So the risk is increased to 24% by the age of 45 years. Ischemic stroke are most commonly seen in children between the age of 2 to 9. So I would just say, like, okay, less than 10 years at risk of having, ischemic stroke. But it's uncommon in the ages of 20 to 29. But there's a second peak at the age of 29 and above. While hemorrhagic stroke are most frequently seen in individuals between the age of 20 and 29. So ischemic stroke accounts for 54% of first stroke events, while hemorrhagic accounts for 34%, and both ischemic and hemorrhagic stroke account for 1%. It's also good to know that transient ischemic attacks account for an additional 8%. So although, not characterized or age dependent, the 10 to 20% of patients have seemed to, have silent infarctions, which is, evidenced by radiographic findings of diffuse white matter disease, while there is no clinical, signs or, symptoms. So these silent infarcts are associated with cognitive deficiencies. I've said that earlier on. And also it's good to know that children with transcranial Doppler studies that are abnormal are 3,000 times at greater risk than those with, without and normal subject. In Africa, stroke prevalence in sickle cell anemic patients is reported to be 4.8%, with a higher prevalence of 8.4% using the WHO criteria. In this criteria, the pediatric NIH stroke scale was actually used to, as a criteria in this study. So stroke prevalence among sickle cell disease patients in Nigeria was observed to be 12.4 per 1,000 patients, and the prevalence in children is 7.4 per 1,000, while in adults it was 17 per 1,000. So a study-based, a hospital-based study done in Ibadan by Professor Lagunju showed prevalence of 6.8% in children with sickle cell anemia.
Now, as a way of pathophysiology, to further understand how this stroke come about in this sickle cell patient, we'll look at, we'll see that individuals with sickle cell disease are at an increased risk of ischemic and hemorrhagic stroke. Now, mechanism underlying ischemic stroke, because we'll start with first looking at ischemic stroke, which is more common in children with sickle cell disease. Now, the mechanism underlying ischemic stroke is typically due to border zone ischemia. Now, what is border zone ischemia? Border zone ischemia are also known as watershed infarcts. These are characteristic infarcts that occur at the junction between two main cerebral arterial territories, such as the junction between the posterior cerebral artery and the anterior cerebral artery, middle cerebral artery and the posterior cerebral artery, or the junction between the middle cerebral artery and the posterior cerebral arteries. Now, these are where you majorly find this ischemia in such patients. Also, we can also see that these infarcts will occur at this point, secondary to anemia, and also secondary to cerebral hemodynamic alteration, which bring about vaso-occlusion, which are caused by an intimal proliferation rather than the thromboembolic disease. Now, unlike the typical and classical ischemic stroke that is secondary to probably a thromboembolic cascade, or secondary to an embolus or an atherosclerotic disease or hypertensive heart disease, in sickle cell disease patients that have ischemic stroke, it's usually more due to anemia as one of the major causes. Now, we know that they usually have a low PCV, which makes them anemic, and this further leads to a decreased supply of oxygen to the brain tissues. Now, a concomitant clinical event such as an acute chest syndrome or an infection with parvovirus B19, which causes reticulocytopenia, will worsen this anemia, thereby starving the brain more of the nutrients and blood supply and also of oxygen. This will bring about an ischemic stroke in this patient. Also, a cerebral hemodynamic alteration is seen in this patient as a predisposing, as a cause of ischemia. How does this come about? Now, the deoxygenated lysed hemoglobin tends to cause a proliferation, polymerization, as well as a change in the flow of the red blood cells through the vessels. Now, what this causes is that there is a complex of neutrophils, platelets, sacral erythrocytes, as well as the endothelial cells. Now, they come together and they cause some form of scarring on the intimal layer of the cerebral vasculature. Now, this brings about an intimal proliferation, which causes a stenosis in the cerebral vasculature. Now, every tissue that is distal to this stenosis tends to go ischemic. And also, this stenosis narrows down and causes an accumulation of inflowing blood, which also predisposes patients to having a transformation of an ischemic stroke to a hemorrhagic stroke. Now, this complex is typically what causes ischemic stroke in this patient. But sometimes you can still see the typical or the classical ischemic stroke where you see some infarct, some embolus, or some thrombus in this patient if they have a concomitant heart disease as well. Also, now looking at hemorrhagic stroke, the stroke is well less understood, and some contributing factors to them could be rupture of a weakened primary vessels or a fragile collateral vessels or an intracranial aneurysm. Some studies have also suggested that Moya-Moya syndrome also predisposes this patient to having hemorrhagic stroke. And all these together, the major and the well-established pathophysiology. But there's a study done by Zeng et al. In 2016, we tried to explain the implication of the nitric oxide in predisposing these patients to further ischemic stroke. The research tried to explain that when the red blood cell lies, it releases arginine-1, which scavenges and prevents nitric oxide production. And what this does is we lose the vasodilatory effect of this nitric oxide, which in turn increases the peripheral resistance and the narrowing and stenosis of these vessels. And in all what this leads to is ischemia and stroke in this patient.
Thank you. So here is a pictorial description of what he just said. So here is the border zone infarctions, and then epidural hemorrhages and hematomas, subarachnoid hemorrhage, and all. Then here is the myo-myo, the plexus of fragile vessels.
So now, as a way of diagnosis, there should be high index of suspicion for every hematologist, every physician seeing an SCD patient whom we are suspecting could be at risk of stroke. Now, the aim is usually to detect, early detection and prevention of having this stroke. Now, when a patient comes in and you're noticing some signs of paresis, is complaining of visual loss, diplopia, or nystagmus or strabismus, there's some speech or language impairments, the patient walks in and you see some gait disturbances, the patient complains of headache, or you're seeing some signs of cerebral ataxia. These are pointers that you should screen and try to rule out stroke in this patient. Now, also seizures, stroke and silent cerebral infarct are reported to be more common in individuals with SCD with a history of seizure. So seizure places an additional risk, and that's something you have to look at when you are taking the history of this patient and trying to evaluate and make a diagnosis of stroke in this sickle cell disease patient. Also, any change in the level of consciousness, though not very common, but can also be an attributing factor or a history that is very important that you do not overlook in this patient. Also, a previous episode of stroke, as you have seen earlier, these patients, when they have one clinical event of stroke, there's always the high possibility of a recurrence, especially within the first 2 to 3 years of the initial stroke. Now, under physical examination, the vital signs are very paramount. We all know that when you're managing a sickle cell patient, the vital signs are more like your eyes into what is going on with the patient. You have to look out for signs like fever. Now, how will fever affect a patient with having stroke? Now, we've seen that a concomitant clinical event such as acute chest syndrome increases the tendency of the patient having stroke. So now, when you see a fever, that should give you a point that is there some form of other crisis going on in this patient? Is there an infection? Is there an underlying infection that can further cause, worsen this anemia in this patient and predispose this patient to stroke? You have to look out for chest signs. Are there signs of intercostal recession, subcostal recession, all pointing towards possible acute chest syndrome that is probably occurring alongside a stroke? You have to look out for oxygen saturation and try to make sure that the saturation is at least above 95% in room air. Look at the hydration status, check for the capillary refill, and buccal mucosa, skin sugar. Look out for degree of pallor. Even before you get your pack cell volume and know the percentage, from the degree of pallor, you can know, okay, is this child predisposed or is he at risk of, having this stroke? Do some proper neurological examination, age-appropriate neurological examination using the pediatric NIH stroke scale. That is a very important scale in grading and knowing, is this patient, am I dealing with a patient with stroke in SCD or not?
Okay, so I'm going to talk more on the physical examinations. So evidence of infection, in as much we are trying to rule out stroke here, and you're looking out for other acute stroke, mimics. You're looking at features of brain tumors, you're looking at features of infection. Are we having meningitis here or viral encephalitis in a patient with sickle cell? So you look out for any focus of infection, and then this age-appropriate neurologic examination, the Pediatric National Institute of Health stroke scale, it actually has 11 domain where you evaluate these children, and the higher the score, the worse and poor prognosis you get. So by investigations, actually, we need to know the baseline values of these children when they present to us in our outpatient, or when they come for their routine checks. We should know their baseline, of the baseline food blood count, baseline electrolytes, then also know their HB quantifications. What is their fetal hemoglobin like? Is it increasing? Is it small? Is it low? So when they present, you quickly run this test, the complete blood count. Are we having, leukocytosis? Are we having thrombocytosis? Are we having severe anemia? So you compare it with what you had earlier when the child is stable, and you know what to do next, because it will be a guide. Also, reticulocyte count, very vital. So there are risk of having stroke when there is reticulocytosis, and you also do a quick typing and cross-matching for transfusion, because one of the specific management is actually blood transfusion, exchange blood transfusion, but we'll talk about that later. Then the percentage hemoglobin S and the fetal hemoglobin. So this will help you know at what level you want to reduce the sickled cell. Then prothrombin time and activated partial thromboplastin time, very vital, because it will also guide you to know, is this a hemorrhagic stroke or is it an ischemic stroke? Then have the electrolytes done to also look out for other things that could cause neurologic manifestations. Is it a hypovolemia or any comorbidities? Then blood culture, septic workup, malaria parasites when they present with fever. Then electroencephalogram is also done, because these children, some of them have seizure disorders. Then they are sickle cell patient or sickle cell anemic patient, then with a seizure. Before maybe another seizure, will what exactly is happening? Is it a child with background seizure disorder, or a child that actually came in with a stroke? Then lumbar puncture should also be done to rule out meningitis, but this lumbar puncture must be done after an MRI or CT is done. And also you have excluded features of raised intracranial pressure. So this will also help us exclude mimics of acute stroke. So by way of diagnosis, it's actually clinical based, and neuroimaging studies will also guide you. We have talked about history and things to look out for clinically, then examinations, what you would see. Then the neuroimaging studies will help you differentiate between ischemic stroke and hemorrhagic stroke, and also stroke mimics like tumors and other things. Then also help you assess the status of the intracranial vessels. So, but the key investigation to do is an MRI, because MRI will help you pick an infarction that occurred an hour before presentation. And then we also can do the MRI is the magnetic resonance imaging. Then we can also do the magnetic resonance angiography, but this one is actually done in in younger adults. You get? Then the CT and CT angiography can also be done, but CT has some limitations. When you give it contrast, the fear of what if it's a hemorrhage, then you're introducing a contrast. And CT will not give you infarction, a clear picture of an infarct or a recent infarct. So MRI is actually key. Then the transcranial Doppler and transcranial Doppler imaging are used as to, to screen children, at least those that are 2 to 16 years, to know those that are at risk of having stroke. But we actually don't use it when they are ill. So here is a pictorial of an MRI of a right hemispheric infarct. So this that we are looking at the second picture, where you have perfusion MRI abnormality in the right hemisphere, and then posteriorly in a in an 11-year-old boy with sickle cell anemia who developed headache after a chest crisis, that he had acute chest crisis, then afterwards developed a headache. And we'll also see the transcranial Doppler maybe later, but here the transcranial Doppler ultrasound of that right vessel shows 200 cm per second on that particular right vessel, and then the left one was is 161 centimeter per second. So here you see the infarctions that has occurred in this child. Then you have the transcranial Doppler. This is the red right cerebral artery and the left middle cerebral artery. So the right middle cerebral artery has the velocity of 220 centimeters per second, while the left one has 130 in a 10-year-old girl with sickle cell anemia that presented with a focal seizure, then had a transient ischemic attacks and a headache. So the picture below shows the magnetic resonance angiography, where you have the right proximal stenosis of this middle cerebral artery. So this is the angiography, and the one above is the transcranial Doppler picture. These are also pictorial stuff of the, ischemic episodes or events in a sickle cell child that is actually asymptomatic, those that have silent infarctions, and those that have ischemias. So transcranial Doppler is actually a non-invasive a non-invasive procedure that you do to screen and know those that are at risk of coming down with a stroke event. So it actually has become a standard of care as a screening test for stroke in children between 2 to 16 years with sickle cell disease. And it's also good to know that for you to actually, go ahead and say that this is abnormal, we have to have an experienced operator carry out this procedure, and also ensure that the child is not ill or received a transfusion 2 weeks, preceding when you want to do the procedure or do the transcranial Doppler. So here is the transcranial Doppler screening tool. So velocity of less than 170 centimeter per second is actually normal. So ideally, when a child presents to the clinic with this, you do annual repeat of this transcranial Doppler. Remember, it's non-invasive. Then when the velocity is between 170 centimeter per second and 185 centimeter per second, it's called the low conditional, range. So TCD is supposed to be repeated 3 to 6 monthly, or you do it 3 monthly or 6 monthly. Then when the velocity is between 185 and 200 centimeter per second, it is called high conditional. So a repeat transcranial Doppler is supposed to be done 1 to 3 monthly. A flow velocity of greater than 200 centimeter per second is actually abnormal, and there is a risk of having a stroke. So this TCD is supposed to be repeated within 1 or 2 weeks. So studies, when you have 2 studies that are abnormal within that 1 to 2 weeks period, and it has demonstrated to be, persistently abnormal, you quickly initiate primary prophylaxis with a chronic transfusion protocol, which we'll talk about later. And also good to know that ultrasound of greater than 180 to 185 centimeter per second of the transcranial Doppler imaging, because Doppler imaging, that TCDI, will show you exactly, like it's efficient to pick exactly the vessel that, you know, it's having challenge. And it's also good to know that it is the internal carotid artery and the proximal middle cerebral arteries that are the vessels used to give us a good report. So a high index of suspicion should be maintained in patients with neurologic symptoms and signs. And treatment goal is to actually minimize ongoing injury to the brain and to prevent stroke reoccurrence. So when a child comes with a stroke, ABC of resuscitation should be the first thing to do. And it's also worth to note that treatment is multidisciplinary. So immediate assessment by clinician with expertise in stroke, sickle cell management team, you have the pediatrician, pediatric hematologist, neurologist, ophthalmologist, and then physical therapists should be, involved in the care of these children. I remember I said earlier that ABC of resuscitation, very key. You monitor the oxygen saturation and supplement when it is lower than 95%. So our target saturation should be 95% and greater. Ensure there is airway protection from aspiration, because some of them have some form of, swallowing difficulties. So before you start feeding, you do the swallow test and be sure that, the patient will be able to tolerate oral feeds. But if not, pass an NG2 and feed, because calorie, very vital. So you take, remember I've talked about earlier about the baseline laboratory test, using it to compare with the investigations that we're going to do when they present. So urgent sickle transfusion is done to reduce the, percentage of the sickle hemoglobin and to raise the hemoglobin to approximately 10 grams per DL and not higher. So this is very important. So when you're transfusing, ensure that you don't, get across 30% PCV hematocrit count. Also, as you're stabilizing the child, you're doing urgent brain imaging. Precaution to minimize crying, because crying will cause hyperventilation. Then any, painful events should also be handled, because we want this child calm, because excessive agitations could lead to hyperventilation and lower the partial carbon monoxide, lower it, and thereby inducing vasoconstrictions and ischemia. We also ensure that there is normal tension, normal euvolemia, normotemia. We avoid anything that will give us hyperglycemia, hypoglycemia, hypocapnia. We, avoid those. So, and it is achieved by, monitoring, cautious monitoring of these patients. Also, intravenous hydration with isotonic fluid should be done to maintain, at least you keep the child at maintenance rate. If you're planning to, you could actually get blood ready to do a top-up transfusion. As you're hydrating the child, you subtract the volume of blood transfused from the daily maintenance of that child. So volume depletion should be avoided, and volume overload should also be avoided. Blood pressure should be controlled. Identify and treat infection if there is any. You treat with antibiotics. Then if there is fever, give antipyretic. If there is convulsions, you manage accordingly. Then manage as a stroke patient. And also we should not forget about the caloric intake of this child. So here is like an algorithm. When a child with sickle cell comes and you're suspecting stroke, based on the clinical features, sudden headaches, convulsions, hemiparesis, and there is a new neurologic deficit, you do rapidly evaluate and stabilize. I've talked about that earlier. access vital signs and airway, ensure you regularly follow up. Then monitor and maintain oxygen saturation. Cardiac and blood pressure should be monitored. IV access should be gotten, and the laboratory investigations done. Empiric antibiotic commenced if there is fever and infection present, and blood pressure controlled. But if you check the PCV or the hemoglobin, you check the hemoglobin level and there is HB of greater than 10 gram per DL, so you hydrate with isotonic fluid and recheck the blood level again. But if it is less than 10, immediate red cell transfusion is done within 2 hours of presentation if the HB is less than 8.5 gram per DL. And remember, your target is not to exceed 10 gram per DL. So you calculate the blood volume to give and to up, to raise the PCV or to raise the HB to 10 gram per DL, sorry, or PCV to 30%. Then simultaneously obtain brain imaging. MRI is the image of choice. Then switch to red blood cell exchange. This could be done 12 hours after the top-up transfusion or 24 hours after the top-up transfusion to reduce the SB level to at least 30%. To reduce the HBS to at least 30%. So afterwards, you do your clinical evaluations, interpret your laboratory findings, interpret your imaging, which will guide you make a diagnosis. So if it's an ischemic stroke or transient ischemic attack, which is likely confirmed by the MRI and other parameters, in adults, you evaluate for and treat the IVT and or MTI for eligible patients. But in children or adolescents, do a complete stroke evaluation, then for mechanism and specific secondary prevention. So you just, hit the ground running by doing the exchange blood transfusion, then followed up with a chronic, blood transfusion. But if after the review of the imaging, laboratory, and then clinical, you think it's a cerebral venous thrombosis, heparin anticoagulation is given regardless of the hemorrhagic venous infarction, and you also evaluate and do the secondary prevention of stroke, which is chronic transfusion. But if it's a hemorrhagic stroke, control blood pressure, treat the bleeding, stop any antiplatelet or anticoagulant, decide if anticoagulant reversal is needed, then platelet transfusion should be done. Consult to a neurosurgeon is immediately done, then obtain MRA, that's the magnetic resonance angiography or CT angiography. But if the stroke, if after interpreting you have a stroke mimic like tumor, seizure, migraine, meningitis, you treat accordingly. So this is exactly what I just said earlier on. You also, work up for other causes of stroke, maybe do an echocardiography to, rule out other cardiac pathology and hypercoagulable workups. So transfusion. Patients with sickle cell disease who have a clinical or radiologic, confirmed acute ischemic stroke, exchange blood transfusion is key. I've said that several times. And the goal of transfusion is to lower the percentage of the sickle hemoglobin by 30% and aim also to not to exceed the total hemoglobin of 10 gram per DL. I've already talked about all this. So exchange blood transfusion, the rationale for doing that as against the single blood transfusion is that it reduces the percentage of hemoglobin, thereby decreasing the vaso-occlusions and further ischemias. And their risk of having another stroke is actually markedly reduced. Because children who have early exchange blood transfusion have a lower rate of recurrent stroke compared with those who receive only simple transfusion, because studies have been done and found out that exchange blood transfusion that is being done every 3 to 6 weekly drastically reduces the HBS level to at least 30 or 20%, and the risk of having a repeat stroke is thereby reduced. And in adults, a high percentage of adults that had TIA had ischemic stroke within 7 days, you get. But it's also what to know that exchange blood transfusion is actually protective. But the simple transfusion now, when you do that, you know, the risk of overshooting, exceeding the 30% hematocrit count or exceeding the 10 gram per dl of hemoglobin is actually there, which could cause hyperviscosity and worsening stroke symptoms or, you know, fluid overload. So that's why exchange blood transfusion is actually, you know, preferred and better. So I will talk about quickly just run through the procedures. It's a type of apheresis. We call it the erythrocytopheresis, whereby blood from the patient is removed to deplete the red blood cell count. And what it does is there's a reconstitution with the donor RBC, and it's being retransfused into a continuous circuit. It's actually demanding, although expensive and all that, and you need a lot of pints of blood to, you know, carry this when you're doing it with the machine, the erythrocytopheresis machine, the circuit machine. So if equipment for automated exchange is not available, we do the manual exchange, which, you know, we are all conversant with. So the apheresis catheter can be removed after the exchange blood transfusion is completed, except you have something else you want to do with it. Then the total hemoglobin and the percentage HB should be monitored. So before you do that, you check the HB quantification before and after exchange blood transfusion. So this should be maintained, like the SB hemoglobin concentration should be, you know, reduced drastically by 30% of total HB for 2 to 4 weeks until another transfusion is, you know, needed. So when you do this exchange blood transfusion, the HB concentration drops by 30%, and it could be maintained like that for 2 to 4 weeks before another transfusion. So Dr. Victor will take us through the differentials.
Yeah, some close differentials to stroke and sickle cell disease includes infections such as acute meningitis. But as we know, in a child with acute meningitis, you'll be seeing signs of meningeal irritations, neck stiffness, prognostic key and mechanic signs will be positive. Brain abscess, sometimes patients who have brain abscess might manifest and show similar symptoms, but of course, there might be preceding history of otitis media, acute tonsillitis, or other upper respiratory tract infection, which would have been a point of access into the brain, causing the brain abscess. Also, cerebral malaria, which you can easily detect when you do, you know, a malaria test. Also, some other seizure disorders, such as the thought paralysis, where you see a post-ictal paralysis following a seizure episode, sometimes mimic or act similar to stroke, but of course, stroke and SCD, but of course, there would have been an established prior history of seizure in such patients. Also, migraine, such as the hemiplegic migraine, has been seen to somewhat mimic stroke and SCD, but of course, there would be a prior history of aura prior to the episode, as well as some studies show that a minor trauma tends to aggravate this hemiplegic migraine in this patient. Also, tumor and other structural brain lesions, such as craniopharyngioma and glioblastoma, could give you that. But of course, when you do an MRI, you can see that of the stroke, like ischemic stroke in these SCD patients, are more at those border zone regions, whereas things like craniopharyngioma would be in the pituitary gland area, glioblastoma in the glial cells, and the rest. Also, alternating hemiplegia of childhood has been seen to mimic, but of course, when you do a genetic testing in these patients, you will see the alteration in the ATP1A genes. Also, posterior reversible leukoencephalopathy syndrome has been also seen, but of course, this is a clear syndrome, and you can easily differentiate, even with an MRI, that this is a stroke in an SCD patient who has a history of, you know, being a HBSS and these other patients. Also, some other metabolic derangements, such as the metabolic disorder of lactic acidosis, have been seen to mimic this. But of course, with proper evaluation, you can definitely separate the two clinical presentation. Demyelination conditions, such as acute disseminated encephalitis, has been seen to have some similarities Also, idiopathic intracranial hypertension, that is the small tumor cerebri, has been also seen. But of course, imaging will not show you anything in such patient as compared to what you find in sickle cell and stroke in a sickle cell disease patient. Drug toxicity such as opioid overdose. I think for this, it's a bit more easier to differentiate, as you will see signs of obvious opioid overdose, such as the constriction of the pupils, decreased heart rate, decreased respiratory rate in opioid toxicity as against the clinical findings that you find in this stroke in sickle cell patients. Musculoskeletal conditions in young, such as Duchenne muscular dystrophy, can also sometimes try to mimic the problems and the presentations you find in stroke in SCD. But when you do probably creatinine kinase for this patient, you might see some elevations which will help you differentiate the clinical presentation or its presentation from that of stroke in SCD patients. Some psychogenic syndromes such as conversion and dissociative disorders, where some people experience some form of trauma, let's say an accident, and wake up having a hemiplegia. In those kind of patients, of course, you can get a history of prior trauma like that. And of course, they are not HBSS. So that can help you make that differentiation between the both clinical presentations.
Okay.
Okay, so some long-term complications that you might have to deal with is recurrent stroke. But this, as we have earlier explained, can be controlled with the right management, such as the chronic transfusions and proper follow-up in sickle cell disease clinic. For academic performance, this is actually seen more with silent stroke in this patient, as most times when they come and if you do not have the clinical knowledge of how to diagnose this silent stroke, you might mistake and say, oh, there are no neurological findings in this patient, they are okay. But then the parents come back, the patient comes back and tells you, oh, I'm noticing some further decrease in academic performance. So it's very important that you know that if you do not pick the silent stroke and infarct in this patient, they are predisposed to having poor academic performance. And also, a full-blown stroke in this patient can still predispose them to this, but of course, proper management with an involvement of the neurologist will help in limiting these adverse effects and complications. Also, some neurological deficits could be there. Some optic neuropathy. We've seen patients that had optic neuropathy following stroke in SCD, and they come down with blindness, some come down with diplopia. But these are things you need to look out for, and the reason why an early diagnosis, and it's very important that this will help you prevent these manifestations in such patients. Also, some of them go ahead to become seizure disorder patients, having status epilepticus and the rest. These are things we aim to avoid through a proper management of these patients. Also, as we all know, there's a possibility of deaths in these patients, which is what we do not want, and which is why we are doing this to educate and to inform. And these are the possible ways to manage this patient and prevent these adverse outcomes.
Okay, so I will take us through the follow-up. Repeat imaging, very vital. So the magnetic resonance imaging should be done in those with TIA, those with silent stroke. You repeat the brain MRI 2 to 4 weeks after the initial presentation. So remember I said earlier on that it will pick even the ones that are not even having some clinical signs and all. So the diffusion weighted imaging of the brain will actually pick if there is new infections or even the old ones. So repeat imaging is very important. Then secondary stroke prevention, we will talk about it later. Secondary stroke prevention is critical in managing these children with chronic transfusion, which could go on for like 6 months or 1 year, or in some centers for like 2 years. Also, cognitive rehabilitation with appropriate age educational resources and cognitive domain specific evidence-based guidelines should be provided for those with silent stroke that have poor academic performance and behavioral dysfunctions. Cognitive rehabilitation should be given to them. They should see the neurologist and psychologist. Then motor deficits, some of them have residual neurologic deficit. They have hemiplegic GERD and all that. Physiotherapy after discharge is also, provided for them. Then ophthalmologist review for those with, remember I said from definition is, injury to the retina, the spine, and, the brain. So they should also see the eye doctors to, quickly check their eyes and ensure they are intact. So primary prevention, by way of definition, is the intervention to reduce the risk of stroke. And I've talked about it earlier on that, in SCD, primary prevention is used to know those that are at increased risk. And what we use to do that is the transcranial Doppler or the transcranial Doppler image. And once you get them early, amazing and fantastic. So whenever their TCD is greater than 200 centimeters per second, chronic transfusion is being instituted. So you start exchange blood transfusion 3 to 6 weekly, and and monitor their HB quantifications with emphasis at looking at the sickled hemoglobin. If it's actually, it will give you a guide of if you're getting good, what you're doing is, appropriate or not, because our target is actually to, reduce that percentage by 30. Also, hydroxyurea has also been used, a study done has been, proved that hydroxyurea has also helped, because this stroke is actually an ischemic episode. So hydroxyurea, what it does is actually to increase the fetal hemoglobin, which is protective and has affinity for oxygen, oxygenation of the cerebral cells and all. So what it does is to prevent ischemic events and episodes that will now reduce the risk of them having a stroke. Then hematopoietic stem cell transplant is also very vital, but it's very, it also helpful, because studies don't show that those that had stem cell transplants, none of them had a stroke event. Actually, that was for secondary prevention. None of them had a stroke event when compared, to those that, had stroke earlier, before those that never had at all. Those that had stroke earlier and had hematopoietic stem cell transplant had no stroke events, but those that never had risk of having a repeat stroke. Then also the agents, new agents, the voxelotor, L-glutamine, and all has shown to have only impact in reducing vaso-occlusive crisis, but the studies done did not show any, validity or any improvements with those that are at risk of coming down with stroke events. So it's actually not necessary, but you could use it for those with acute painful episodes or those with acute chest syndromes, but with stroke events, no. Secondary prevention refers to intervention to reduce the risk of reoccurrence in individuals who have already had a stroke or had a silent, chest infarction. Chronic transfusion is the treatment of choice of secondary ischemic, prophylaxis. Also, the hematopoietic stem cell is also highly effective, but it's limited availability. People travel abroad to get this done, and also the burden of the complications, and these children will come down with, you just weigh the risk and the benefits and all. And there is also limited evidence of effectiveness of hydroxyurea therapy in this patient population for those with secondary prevention. So the earlier we study hydroxyurea therapies for stroke prevention, in primary prevention, the better. But okay, I'm going to also talk about, okay, this revascularization is another part of secondary prevention, but it's actually for those with Moyamoya syndrome. Remember, we talked about it is a genetic disorder that has arterial stenosis and occlusions around the circle of Willis that leads to, rupture of these vessels and then hemorrhagic stroke. So the clinical manifestation of moya moya includes transient ischemic attack, ischemic infarction, and cerebral hemorrhages. This revascularization is actually the procedure is actually done by neurosurgeons to help. Yeah. So now I'm going to talk about the transition from chronic transfusion to hydroxyurea. Because hydroxyurea takes a while before we get the maximum tolerated dose in a child, it will take like 6 months for the patient to tolerate it. So it's advised that hydroxyurea is commenced when the exchange blood transfusion or chronic transfusion therapy is ongoing. Then the child will be able to now, accept or tolerate the hydroxyurea, and then you start seeing the effect. So transiting, completion of 1 to 2 years of chronic transfusion with consistently good control of HbS levels during this interval, one can gradually transfer from chronic transfusion to hydroxyurea. Actually, it was a switch therapy, like TCD with transfusion therapy changing to hydroxyurea, which was done in the US. So these are their, parameters to switch to hydroxyurea. Then normalization or improvement of TCD velocities on transfusion. No evidence of severe grade 4 or higher vasculopathy on magnetic resonance angiography. And this is when there is a 50 to 74% stenosis in more than 2 arterial segments, or a severe stenosis of 75 to 92%, or occlusion of 1 or 2 arterial segments, which is being seen on the magnetic resonance angiography. And also ability for the child to tolerate the hydroxyurea treatment protocol, because some of them don't adhere to these medications. Once you commence it, they will now say they felt this way, felt that way, and they stop. So counseling on how to sustain this therapy, and that is going to be for as long as they have to be on it, because the benefits actually outweighs the risk. The side effects are less and is cost effective too, as compared to chronic blood transfusions. If it's done in an automated way, it's quite burdensome, but our manual procedure helps us. So hydroxyurea is not the optimal first-line therapy for primary stroke prophylaxis. Why? Because the efficacy of hydroxyurea as an upfront primary prevention in comparison with chronic transfusion has been tested in a randomized trial, and chronic transfusion supersedes. So typically, at least 6 months of a therapy, I think I've talked about this, are required to reach the maximum tolerated dose and maximal clinical response to hydroxyurea. So during this time, the patient may not have adequate protection for progressive vasculopathy and stroke risk. So it supports with chronic blood transfusion. Response to hydroxyurea therapy is highly variable. It's actually individual dependent. This patient might tolerate it and get good response, while another individual may not. Yes. So response to hydroxyurea therapy is also highly dependent on individuals. So adherence to therapy is very, very vital. Although it's difficult, but you just plead with these parents. Yeah. So prevention of hemorrhagic stroke. There is little evidence for effective primary or secondary prophylaxis of hemorrhagic stroke in patients with SCD, although we still do the chronic exchange and top-up transfusion. The potential benefits of chronic transfusion and hydroxyurea therapy have not been established, but either would be a reasonable option. What do? We just do that. So children and adults with overt stroke may benefit from surveillance MRA with MRI. So the Association of the American Society of Hematologists actually put up this guideline that the magnetic resonance angiography and MRI should be carried out in school children and adults so that they'll be able to pick up infarcts as we also do the transcranial Doppler as a screening test for, overt stroke or those that are at risk of, overt stroke. So patients and family, caregiver, clinicians may elect for additional therapy to, attenuate the risk of cerebral infarction, recurrence. So, such as hematopoietic stem cell, I've talked about that. In children with HBSS and abnormal transcranial Doppler velocities that are placed on regular blood transfusion as a standard care, the presence of MRA-defined vasculopathy will actually determine eligibility for those that will transit to hydroxyurea after 1 year or 6 months of regular transfusions. Yeah. So thank you so much. So we are open to questions and no, thank you. Okay.
Very good questions.
Okay. Thank you for the questions. I'll take the questions now. What is the most common type of stroke in a patient with SCD? Okay, earlier on we talked about at the epidemiologic level, we said that ischemic strokes occur in those with age of 2 to 9 years and then picks up again at 29 years and above. While hemorrhagic stroke occurs in those that are more commonly seen in those that are 29 and above. Okay, I guess I've answered that. So why MRI and CT before a lumbar puncture? Because you want to rule out intracranial hemorrhage and Remember, we talked about the subarachnoid hemorrhages that can, seep into the, you could find that those bleed into the cerebral spinal fluid. Yeah, so it could actually leak and extend there. So you actually don't want the child to cone. So when you're looking out for, you check out your features and of raised intracranial pressures, and also do a CT or MRI so that you don't stick in a needle and the patient cones. Okay, atrial fibrillation as a risk factor for hemorrhagic stroke. These are common causes in adults, not in children with sickle cell. Yeah. Likewise, how reliable is the TCD as the patient gets older? Many times. Okay, studies done by I think STOP, the stroke prevention trial in the US. They did a study in those that raised more than 16 years and in older people, but they found out that it was a randomized trial. They found out that it's actually not helpful, that TCD should be done in those 2 to 16 years. So MRIs to rule out the silent cerebral infarct and other diseases, because in older people, a lot of things will trip them into having hemorrhagic stroke. I said that those that are 29 and above are at risk of having hemorrhagic stroke. So in older children, in older patients, TCD will not fly. It's not reliable. But the magnetic resonance imaging and magnetic resonance angiography, it's actually a reliable imaging method. At what point should a sickler with stroke be admitted in ICU? Okay, when the child is unconscious and unresponsive, and when you check the Pediatric National Institute Health Stroke Scale, and it's quite elevated at 45, 40 to 45 scale, they should be admitted in ICUs and monitored closely. And also when they are having some form of other complications, unconscious, respiratory embarrassment and all, they should be admitted. But if it's a child that has hemiparesis and could talk, could tolerate feeds, there's no need taking them to ICU. You can manage in the ward. Okay, thank you. As most centers do not have the machine for exchange transfusion, could you please dwell more on the practical way of doing EBT, possibly the step-by-step approach to it? Okay, thank you so much. Some centers actually have the machines, yes, although very expensive, very, very expensive and demanding. The practical, normal way, alternative, yeah, but the practical way, the way you said it, practical way of doing the exchange blood transfusion. Step by step, you assess the patient, ensure that the vital signs are good, then also ensure that the PCV is not less than 21%, so the head and hemoglobin count should not be less or equal to 7 grams per TL. Because if you have hemoglobin of that value, you have to do a single top-up transfusion and work the patient up for a next exchange blood transfusion, maybe the next day or 12 hours after. Then you group and cross-match and get your AA blood, sedimented AA blood, red cell, they are sedimented cells, AA blood. Then It depends because there are a lot of
Factors to consider.
a lot of protocols, um, a lot of a lot of people have different protocols. But what works for me or what I use, you either do a 6 meals per kg let out and a 12 meals per kg top up transfusion. But this is based on the clinical, features and clinical parameters of the patient. So it's, either here or there. When you check the clinical scenario of the child, you will know what works for you or what could work in that state. So you calculate that, let out some blood and now transfuse with the sedimented, and the let out is done for 30 minutes and you check your vitals every 15 minutes afterwards you now do a top-up transfusion. And before that, before the procedure, you do your head quantification before and after the transfusion so that it will guide you to know the level of drop of the HbS hemoglobin here, and observe the child, observe the clinical parameters, watch out for seizures, watch out for, improvement in the Glasgow Coma scale and all. Thank you. Do we wait for 24 hours after exchange to take the sample for HPLC? Yes, you do. Or can it be taken immediately? No, you wait for 24 hours or 48 hours after exchange blood transfusion before you do that. Okay, you get the slides. How do we manage those that present with history of a CVA late? For example, 1 month before stroke. Do we still do exchange? Yes. So if they come with history of stroke a month following, yeah, a month, the way they present to you are like having a stroke a month before presentation. We talked about the secondary prevention, because remember they have 67% risk of coming down with recurrent stroke if not managed cautiously. So we start them on that at least for 3 months to 6 months, then switch to hydroxyurea and cancel. Yeah, because if it's outside abroad, the exchange blood transfusion is actually done for a year, and the burden of chronic transfusion, the alloimmunization, iron overload, transfusion reactions and all. So, and also the financial implications and cost. With the slides, so yes. Is there any place for prophylaxis use of aspirin and to prevent stroke in pediatrics? No, we did not. I did not come back.
The pathophysiology
it was actually debunked. Yes, it is not. It is not the atherosclerotic ischemic cascade or pathology. So aspirin and clopidogrel, it's not used to prevent stroke in pediatric sickle cell patient. Thank you. Thank you. My question is for this target HB, any room for consideration of patients' stable HB, or must transfusion occur once it is less than? Okay, this are broad standard, but as transfusion must be considered when it's less than 7 grams per dl. Top-up transfusion should be, because there is already a clinical challenge, a CNS involvement is already facing you. So in as much that the steady state hemoglobin, maybe it might be 7 grams per dl, but there is a complication looking at you here. So you top up and transfuse, because in a bit of trying to exchange with a very low hemoglobin, which possibly might be the steady state, might tip the child into shock and severe anemia, which you don't want to, have or experience. Are there problems associated with multiple exchange or transfusion? Yes, I've talked about that. How low immunization, iron overload, transfusion reactions, those and the cost also.
But you weigh the gains versus the
Yeah, and even the burden and stress on the caregiver. Is there a place for the use of aspirin in patients with sickle cell who have stroke? Well, we've talked about the pathogenesis. There's no place for aspirin with those with ischemic stroke. Thank you. Please kindly re-explain the role of chronic blood transfusion in sickle cell management. Okay. What it does, chronic transfusion, what it does is that it reduces the HbS by 30%. And when that happens, that reduction could last for like 2 to 4 weeks. You get, it could be that low, but if there's no exchange blood transfusion, the risk of having another stroke, it's very high. And another thing is that it will also guide you not to exceed the hemoglobin of 10 gram per dl, which you would get when you do a top-up transfusion. I don't know if I've answered that.
I hope you understand that the chronic, the blood transfusion you're talking about is
Is exchange.
So
it's actually exchange blood transfusion. It's not top-up. It's not simple transfusion.
Yeah.
I didn't get the explanation on how acute chest syndrome is a risk factor. Dr. Victor, maybe he will just talk about it.
Okay. Basically, these patients are already anemic. The brains are already being starved of adequate oxygen. Now, when you have a concomitant clinical event, such as an acute chest syndrome, that means that these red blood cells are not going to be, there's going to be a drop in the level of oxygenation of the already depleted red blood cells of oxygen. So now you have an event that the red blood cells are already not getting enough oxygen in the normal, even when these patients are in their steady state, you're trying to make sure it's above 95%. And then you're having an additional infection, something that's leading to an acute chest syndrome. So that further reduces the availability of oxygen supply to the brain and worsens the anemia that these patients are already having, and of course worsens the ischemia that will result from the insufficient oxygen and blood supply to the brain. That's basically how that comes about.
So hypoxia, hypoxic effects, and the cascade of events. I hope he answered your question. Thank you for explaining, Doctor. Please, I will know if the pathophysiology of fever in the stroke patient apart from the chest infection. Thanks once again. Okay, do you want to talk about that? Okay. Pathophysiology of fever. What does fever do? Interleukins are released, and what do? High fever will cause lysis of red cells. And what will the red cells do when there is anemia? Severe anemia. In fact, I think we talked about in the risk factors, we discussed that both severe anemia, leukocytosis, raised white cell count, and
depleted
red blood count, that they will cause, both of them will cause both hemorrhagic and ischemic stroke.
It helps in forming the complex with the endothelial cells as well as the platelets, and cause further intimal proliferation. That causes stenosis and worsens the stenosis that is already going on in the cerebral vasculature.
So that's where the fever will come in. Fever will worsen. In fact, I keep telling my parents or my guests and their parents that the only thing I don't even want my sickle cell guests.
Why consider the unit hospital? Why should you refer to us? Number one, we have consultants and residents available to attend to referral cases. They are available 24 hours, 7 days a week. And we also give detailed referral medical reports. When you send referrals, we give you a detailed referral report for your guests or for your patient. And we can also discuss and collaborate with your facility if you want to reflect your cases to us. We are open to partnership with your hospital. And you can access a bit of the art transport incubator. It's a specialized transport facility that is readily available to ensure that the transfer of delicate newborns from partnering hospital is successful. And we also have automobile as equipment and the right systems. So the Nimi Children's Hospital is one of the arms of the Nimi Hospital Group. We have found that at the mobile data percent to say to Abuja. As you can see on your screen, the phone numbers you can reach out to us. You can also reach out to us through WhatsApp. You can also send us an email to the email to referrals@limittranshospital.com. You can also visit our website, limittranshospital.com. You can engage on our Instagram pages. If you check the chat box, I drop a link for you to join our WhatsApp group. So thank you so much for participating. We do these webinars twice in a month. I still have one coming up on the 26th of this month. So we were to register for all those who participated, who sent in slides, who sent in CME, CME. So thank you so much. We hope you have more of you. Thank you. All right.